Hi, this is Betty Long, founder and CEO of Guardian Nurses Healthcare Advocates. Welcome to Season 7 of the Lighting Your Way podcast, a season in which I continue to talk with my Guardian Nurses colleagues and hear from them about their day-to-day support of our patients and clients. Their stories are heart-wrenching, uplifting, empowering, frightening, captivating, and true. Welcome to Season 7. Coordinating care in hospitals and outside hospitals is difficult enough when you're in person and actually in the hospital. But it's a whole different story when you're dealing with patients all over the country, as our team at Holman does. Both Jeanette Meredith and Diane McCaffery manage patients in 8 different states besides the home base of New Jersey. I hope you enjoy listening to their stories and learn a little bit about a safe discharge. Ladies, welcome to the Lighting Your Way podcast. This day I have Jeanette Meredith and Diane McCaffery. Welcome to both of you.
Thanks for having us, Betty.
I always enjoy talking to you. I know that you are both doing amazing work at Holman, which is where, or I should say every day, that you support their employees and family members. So, Jeanette, you are the senior member of this mobile care coordinator team. Why don't you give us a little introduction to who Holman is?
Sure. So we began our relationship with Holman back in September of 2019, and they have approximately 8,500 members. So that's all their employees and their family members that are part of the healthcare insurance. The employees range from auto mechanics to accountants to fleet management, kind of roadside assistants with the fleet management that work in the call center, up to, CEOs and administrators.
So this is Holman is based in in South Jersey.
Yes.
But they have multiple, sites, if you will. Tell us about how many states you typically deal with.
So they're actually a global company. We only, not that we only, but we help the employees and their families that reside within the United States. So about 4,000 of those people live in the tri-state area, and the other 4,500 or so, they are kind of spread out across the U.S., Florida, Texas, smaller numbers in the Midwest and the West Coast.
That's a lot of territory to be a mobile care coordinator.
We need a Guardian Nurses jet to fly us around.
Well, I'm glad that part of their business is an automotive group because, yeah. So all right. So you mentioned all the members in different states, and you are the acute nurse, and Diane, you are what we call the complex nurse. So the two of you form a team to support the 8,500, as we call them, belly buttons. Jeanette, your role in the acute phase, tell us about that. What does your day look like?
So I identify patients that have been hospitalized, admitted to the hospital, based on some reporting that we receive from the fund. And I mobilize out to the hospital and walk in their room and meet with them and, try to make sure that everything is going smoothly, answer any questions that they may have, and, try to help steer their care so that they're receiving testing promptly and, not just sitting there spinning their wheels, laying in the hospital bed.
Mm-hmm. Yeah. And Diane, you're the complex nurse, and Jeanette, I'll get back to you because I have a question about your visits to the hospital. But Diane McCaffery, you're the complex nurse, kind of supporting the patients who have diagnoses like diabetes and maybe COPD, coronary artery disease, which, things are not going to go away. So that's how we describe the complex. So what does your day look like?
So I kind of get to reach out to the members that have those complex uh, conditions, and I get to know them. I form a little relationship with them and some trust with them. Make calls throughout the month. I usually, make sure they're seeing the proper doctors or an endocrinologist. Diabetics, making sure they're getting their eyes checked, their feet checked, and also making sure that they have access to all the great Holman benefits, because they do have some good benefits, like Livongo for the glucose monitors and blood pressure cuffs. They also have a digital scale that they can use that also hooks to an app on their phone.
Wow.
And then they also have dietitians that they can see multiple times throughout the year. And that stuff is all free for them. So it's a great benefit, and a lot of them don't know about it.
Oh. And do you connect them with the resources and then follow them? Like what's a typical engagement for you? How long does that last?
Some of the members I've been engaged with for a year. Most of the time I get them settled into like a routine with their doctors. Like, for example, if they're diabetic, once they hit like a stable level, I'll call them just every couple of months so that I can just make sure that they're still doing the right things. And sometimes they come up with questions they might, want answered. I always tell them, they can always call or text me with whatever questions they have or needs they have.
Great. Yeah, because it's a lot a newly diagnosed diabetic, I'm sure there is a lot to understand and to manage, and to have somebody like you who knows as a nurse that, this is how you work your glucometer and this is what that means, right? That can be helpful. Jeanette, I want to get back to you in terms of when you walk into a hospital, and Di, I know you go into the hospital too if one of your patients is admitted, but when you walk into the hospital, do you find how do patients receive you? Let me start there.
Well, I'd say it's mixed. Most are very receptive once I tell them I'm part of their benefits with Holman. There to help them navigate the healthcare system and make sure, try to help improve their experience while they're ill. So for the most part, they're very receptive.
And when they're not?
When they're not receptive, sometimes they're a little leery. They're not sure who I am, how I knew they were in the hospital, why I have their information. They're a little nervous about that. So
Right.
I explain it to them. I offer, to have them verify who I am through human resources, because I work with a bunch of the employees in human resources on a regular basis. So I offer that. And then if, they're still a little leery or not willing to make that phone call, I'm not too pushy, but I just give them my information, let them know that I'm here to help them. Everything's confidential. And I'm happy to do, whatever they need to, help make their experience better.
I can imagine. I've thought of this before. I can imagine what it feels like to be in a hospital bed when you're not getting a whole lot of communication, and then somebody comes in and says that they're your nurse and they're just there for you, and it's kind of like Christmas.
Yeah.
Like, oh, okay, you're just here for me, and you're going to help me. Okay, it does seem a little. You got to be incredulous. But invariably, I'm going to guess that some of those guys and gals call you back.
Oh, absolutely. And most of them are very happy that we're there for them. And they just can't believe that, someone is there in the hospital room to help them.
Right.
Now, the members, of course, that are in Texas and Florida and the Midwest, I reach out to them by phone and help them coordinate their care by phone.
Okay. Your job is to work with these folks who are hopefully not in the hospital, but on occasion, I'm sure there are patients that you're working with who are admitted. So you have a kind of a different take because they probably know you already, right?
Yeah, this is true. Usually they'll be like, "Oh no, you won't believe what happened." You know.
Oh no, I'm in the hospital.
Yes,
Yeah,
yeah.
yeah.
So I
Um,
usually try to, if they're local, I'll go visit them at the hospital like Jeanette does. If they're far reaching, like Texas or Louisiana, one of the far reaching states, I'll communicate with them via the phone.
okay.
Um, and, I usually like to find out like, oh, what's going on? What's your diagnosis? What meds do they have you on now? And usually try
Okay.
to educate them about those things, like what the diagnosis is, what medications they're on. Oh, you're on that prednisone. Oh boy, your sugar's going to be spiking with that one.
Okay.
You know.
Yeah. Do you ever like? I know one of the questions that I am often asked when I'm out giving presentations. And Jeanette, I'll ask you first. What's the response that you've had anecdotally from nurses and doctors when you've been in the hospital doing your role?
I have to say, initially, they're a little guarded because they don't necessarily understand our role until I explain it, in further detail. Um, but they're a little defensive at first. But once they know we're there to help and we're part of the team, they usually come around and are happy to have us involved.
Okay. Di, how about you? What's your experience been?
Yeah, I think at first they're a little like, "Who are you?" And then, once you explain, "Listen, I'm here, his advocate or her advocate, and I'm just part of the team here trying to have a smooth transition for everything." And sometimes they find it very helpful. I know there was one case where a member was going to be on a long-term medication, and I was able to, look on the formulary and see what medications were covered for a member, and that was
Mm.
super helpful for a doctor.
Oh, that's great. Yeah, because no, physicians do not know typically what's covered because there's so many different
Mm-hmm.
formularies, right? I mean, they deal
Yes.
with hundreds of patients all the time. So good for you. um, so I'm going to go back to you, Jeanette. In terms of your role with the acute patients, obviously you're going to identify some folks who might have a complex care or a chronic diagnosis like Diane was talking about. Do you stay involved with them or what's the protocol?
So, what I typically do is work with them until they have maybe their first follow up visit with the doctor. Once they're done tweaking the medications, I feel like I get them tied up with a bow and kind of get all the wrinkles ironed out. And then I transfer the patient to Diane so she can work with
Okay.
them.
Well, Diane, it's better than getting what we call a dump, right? Where
Yep.
Jeanette's not doing anything, just saying, "Hey, Di, I got a patient for you."
Yes, yes. Jeanette always gets them tied up nicely, and then I get to
That's
meet
right.
them, and we do our introductions, and I usually follow along with them after that, whatever their diagnosis is, with education, making sure they're able to get their medications, educating them on the medications, and making sure they're taking them properly, and getting them set up with follow-up care. And sometimes they need to find doctors, and we can do that, and sometimes get them appointments quickly
Right.
if that's
Yeah,
the
that's
case.
really important because
Yeah.
these days there's such a logjam of patients trying to get in, especially if the doctors are well regarded. Right, there's a long
Yeah,
list. Right,
that's true.
it's
That's true.
trying to get into a Broadway play that nobody sees versus one that's selling out every night. Big difference.
Exactly.
Jeanette, is there a case that you can remember or that kind of stuck with you where you did transfer to
Yeah, there
Diane?
was a gentleman in the hospital. I walked into his room and introduced myself. He was there with diabetic ketoacidosis. So I met with him, did a home visit. He was discharged that day, did a home visit the next day, helped make sure he had all the correct medications, had his prescriptions filled, worked with him to connect with a dietitian, and also with an endocrinologist. He had a primary care physician that was not managing his diabetes very well. So, so right away, within a couple weeks, we were in with the endocrinologist. We also had him scheduled with the diabetic educator at the endocrinologist's office, and the nurse practitioner at the endocrinology office ordered a Dexcom so that he could do continuous glucose monitoring.
Oh, okay. Okay. So that's a lot, right? I mean, that's a lot. I can understand why you said get them all
Yes.
neat and tidy and tie them up in a
Yes,
bow.
I
right?
attended his appointments, and once we kind of made sure things were ironed out, then I passed him on to Diane.
And Diane, how was that for you? So did you tell the patient that, hey, my time with you
Yes.
is now concluded?
Yeah, so from the
but my colleague will be picking
from
up.
the start, when I met him, I explained that I would help him through this acute phase of his illness, and then I would be transferring him to my partner, Diane, who is part of the team at Holman, and then she would take care of him from that point on.
And was that he was okay with
Absolutely. Mm-hmm. He was very open to it.
Yeah. Do you sometimes find patients holding or not wanting to go?
Well, I do have a few that have been with me since the start of Holman and guardian nurses relationship. So there's a few that I hold on to that didn't want to start over, kind of, and have to tell their whole story to somebody new. So yeah, there are a few that have latched on.
And that must be hard to, tearing them away from
They didn't
Jeanette.
even give you a chance.
Right. It's nothing.
That's
nothing
right.
personal, Diane.
I
That's
know,
nothing
I
personal.
know.
No,
It's okay.
I'm sure it would be the same way if you had to transfer them back to Jeanette.
No, I think that's quite the compliment for Jeanette, to be honest with you.
Thank you.
Well, yeah. I mean, you develop that part of the joy of this job
Yes.
is develop relationships with patients, and sometimes, like Jeanette said, that they're in there for the long haul, right? They're there for a year, too. I mean, certainly with as your practice evolves, you're going to have patients like that too. Hopefully,
yeah.
Go ahead.
Yeah, I have lots of members that, not lots, I have a handful that, live in the area that I would consider friends because we've got such a great bond,
Right.
Which is great because then they're not afraid to ask questions.
Right. Well, and they know who you are. I think that's one of the unique differentiators for us in our mobile care program and in our advocacy services as well, because when you show up to a hospital or you show up to a doctor's appointment and people can see you and got a sense of you, pick up on your energy, get the fact that you really do care about them, it makes a difference.
Betty, it's funny that you say that
It
because
does.
I've had so many people say, I feel like you're the only one that cares. I'm calling the doctor's office and nobody's listening to me, and you're here and you're listening and you care, and you help get things done.
Yeah. I mean, I've heard it too also from when I was accompanying patients, is that I think you gals may have heard this, but when they come out after the doctor's visit, they'll say, I've never had that much time with him or her. Right. And I say, oh, they're just showing off. Because they're showing off because I was in there. Yeah. Di, I want to get back to you in terms of the relationships that you have with patients. You are in there for the long haul. It's always goal directed. And your attempt really is to keep them out of the hospital because nobody wants to be in the hospital. And we certainly don't want anybody to be there. But is there a story that you could share with us where there's a lesson, kind of a tidbit at the end for our listeners?
So I have a great relationship with a Holman member that lives in Texas, long reaching. Unfortunately was a diabetic, ended up in the hospital after I was, contacting him, trying to get him, on the right track. And then he ended up in the hospital and unfortunately had to have toes amputated from his one foot.
Mm.
And they were discharging him 2 days later, which he really was not prepared for and did not realize he could say, no, I need to stay here and get all the details of my discharge okayed with me, because he's also part of the plan.
Okay.
He needed home care set up, and when they were coming out, then he also had a PICC line for long-term antibiotics, which a PICC line is access for IV antibiotics.
Okay.
Which you have to be super careful with because it's, risk of infection. So home care usually handles all that. And also needed a wound care doctor, follow-up care with them, follow up with infectious disease. And unfortunately got discharged without any of these things. So it was a lot of phone calls. The one doctor was super great, did call me back, gave me wound care orders, which I passed on to the home care, got them to come out. Had to contact the insurance to find out how he got his, wound care supplies. And we got that all taken care of. And then also
wasn't the case manager at the hospital like in that day? I mean, what happened to the discharge planning?
I have no idea what happened to discharge planning. It was a late night call to actually the charge nurse I had to make to say, who is the home care? Why don't they have supplies? All those calls had to be made. But they were very good. The nurse did hook me up with the home care nurse, and I did actually have a great relationship with her now. And we got that all set up. But yeah, it should have been the case manager that followed through with all these things and made sure that the patient understood all the things that were going to happen. Like, your home care is going to be out tomorrow and they will do the IV antibiotics and they will flush your line. And you need to follow up with these doctors. And unfortunately, those things weren't in place.
Oh, God. So, So this is why patients are readmitted to hospitals, because the discharge is quick. Sounds like it's quick if they amputated his toes and then sent him home. And there's a lot, that he has to process.
And there was no education either. He didn't know, what am I doing? What's this? What do I do with this wound? Am I allowed to walk on it? Am I not allowed to walk on it?
Jeez.
Do I have to keep it elevated?
Yeah, look, how many times have we heard that? And it wasn't in Texas. It was in New Jersey, Pennsylvania.
Happens everywhere.
It doesn't matter. Florida. I think the discharge, one of the biggest problems I think we have in healthcare is that the discharges from hospitals are rushed, sometimes not very comprehensive. And patients, to your point earlier, may not be saying, I'm not understanding that, right? So, Di, what's the lesson that you'd like to take from that for our listeners? What would you like to encourage them to do if they're admitted to a hospital?
They have to have good communication with their nurse, their providers, with the case manager, and make sure they understand everything. And if they feel as though something is not working out in their favor, they should say, no, I am not being discharged till X, Y, and Z is taken care of.
Okay. And I'm going to guess that might be met with some resistance. So if that is the case, because hospitals want to get patients out so that they can get more patients in, what do you encourage patients to do, or family members?
They need to just keep saying, no, we are not going. We need to talk to the doctor and make their concerns known.
Right. And I think one of the, I guess one of the, not the trick, but one of the phrases that I encourage patients and families to use is, this is an unsafe discharge.
Exactly.
Because that is, in essence, what it is. You're anticipating that I'm going to probably come back here 24 to 48 hours later. But unsafe does ring a lot of bells in the healthcare world, unsafe discharge particularly. And if they, are able to speak to a doctor, and sometimes doctors aren't available, then it's, case manager, or as you said, the nurse, certainly, case manager. There's nursing supervisor. So there's other people that you could ask to speak to. But I think, to your point, do not go home if you are not understanding your game plan, right?
Exactly.
And he had the availability of you, right? Just imagine all the patients that get discharged that don't have a Diane McCaffery.
Yeah. He would have definitely ended up back in the hospital.
Yep. I'm going to guess.
He doesn't be. Where he doesn't want to be. Yeah.
Yeah. No one, I mean, listen, the hospitals are the worst place to be. There's infections, there's short staffing. Yeah, it's not a great, if you have to be there, it's okay, but not if you don't. And if you can avoid it, do it. So ladies, thank you for sharing a little bit of your day with me. I appreciate it. Jeanette, thank you for leading Diane into a year already, Di. That's pretty impressive. That's
I
pretty
know.
cool.
I'm so lucky to have Jeanette.
Thank
I'm
you.
lucky to have all the girls as backups here.
Yeah. We got a good team. Jeanette, you're doing a great job. Di, thank you for joining our team and for joining today on the
Thanks, Betty.
podcast. And we'll talk to you soon.
Thank you, Betty. Thanks.
Okay. Bye-bye.
Bye.
Thank you for joining us this week. You can find the Lighting Your Way podcast on Apple Podcasts, YouTube, Spotify, and Stitcher. If you liked what you heard, tell a friend and leave us a review. You can learn all about Guardian Nurses Healthcare Advocates on our website, guardiannurses.com. So until next time, find some joy in your life, pet all the good doggies and kitties, and remember to tell your people that you love them. Take care.